Hello everyone, in this video we are going to discuss about pulmonary embolism. So what is pulmonary embolism? It is a life-threatening condition caused by obstruction of the pulmonary artery or one of its branches by a thrombus that is nothing but a blood clot, often originating from the deep veins of the legs, that is deep venous thrombosis. It can result in impaired gas exchange, right ventricular strain, and if untreated can lead to cardiovascular collapse and death. So to know the probability of this pulmonary embolism, we have one criteria called as modified Wells criteria. Here there are few things and each one is given few points. So let us see the modified Wells criteria. First one is clinical signs of the deep vein thrombosis. For this we will give 3 points, and pulmonary embolism is the most likely diagnosis. For this we will give 3 points. Heart rate more than 100 beats per minute. Here 1.5 points are given. Immobilization or surgery within past 4 weeks, 1.5 points are given. Previous DVT or pulmonary embolism, 1.5 points are given. Hemoptysis and malignancy, for each one 1 point is given. So we will cumulatively we will add the points. If it is more than 4, pulmonary embolism is likely. If it is less than or equal to 4, it is pulmonary embolism is unlikely. So let us see how we will approach this case. Pulmonary embolism is suspected, then in this case, and hemodynamically unstable patient. If the patient is not hemodynamically unstable, we have to assess with the modified Wells criteria for the probability. If it is less than or equal to 4, we have to perform D-dimer test. If it is negative, we can rule out pulmonary embolism. If the D-dimer test is positive or the Wells criteria, that is modified Wells criteria score, is more than 4, then we have to perform CT pulmonary angiography. Here, if it is negative, we can rule out pulmonary embolism. If it is positive, we have to treat for the pulmonary embolism. Next we will see when the pulmonary embolism is suspected clinically and the hemodynamically unstable patient, then we have to do bedside transthoracic echocardiography, and we have to assess for the right ventricular dysfunction. This picture is showing transthoracic echocardiography where there is saddle pulmonary embolism and left-sided pulmonary artery thrombus. So here if the patient is having RV dysfunction, right ventricular dysfunction is present, then we have to perform CT pulmonary angiography if available. If right ventricular dysfunction is absent, we have to check for other causes of shock, other cases and other causes of shock. So if CT pulmonary angiography is contraindicated in any cases like any pregnancy or any allergies where we cannot give the dye, then we have to perform ventilation perfusion scan. Here if it is normal, we can rule out pulmonary embolism. If it is high, we have to treat the pulmonary embolism. If it is low or indeterminate, we have to use a clinical judgment, or we can perform Doppler if DVT is suspected. So this is CT pulmonary angiography, which this is normal pulmonary artery trunk, and the right side is showing pulmonary embolism where we can see embolism. So the dye is not being diffused because of this embolism. Next, risk. Based on the pulmonary embolism signs, we can stratify the risk level. If the patient is in hypotension or shock or unstable patient, it is massive pulmonary embolism. Urgent treatment like thrombolysis like altiplase is given and embolectomy can be done. And if it is submassive pulmonary embolism, patient will have right ventricular strain and troponin elevation. So anticoagulation with or without thrombolysis we can do. If a patient is having only minimal signs, it is outpatient care we can do. Anticoagulation if possible we can give. Next, in cases of stable outpatients, rivaroxaban and apixaban can be given. We don't need to give any bridging heparin therapy. In hospitalized and stable patients, low molecular weight heparin, then warfarin can be given. For warfarin, we have to do INR monitoring. Next, for renal failure, we should give unfractionated heparin because it have short half-life and it is reversible. And in pregnancy, low molecular weight heparin, we should avoid any warfarin and rivaroxaban and apixaban like things, because the low molecular weight heparin is safe in pregnancy, so we can give this drug. So this is our overview of this pulmonary embolism. One thing is there is one triad called as Bichos triad. It consists of stasis of blood flow, endothelial injury and hypercoagulability. All this will lead to increase in the pulmonary embolism formation. So this is which was tried. So overall, this is the pulmonary embolism overview and important points in the pulmonary embolism.